Hey Jim, how you doing?
Hey, I'm doing well, Ralph. How are you doing today?
Today is a good day.
The sun is shining.
Yes,
All is
and
well with the world.
it's reasonably mild out.
Reasonably. Okay. I don't know if we're shouting or not, but I'm going to turn us down a little tiny bit here. Okay. Yes. Well, we talked last week, or in our last podcast, about the DSM, the Diagnostic and Statistical Manual of the American Psychiatric Association. And it's used by social workers and psychologists as well as psychiatrists to classify emotional disorders. That's not the only one. The ICD is another one from the World Health Organization, and the two of them are fairly congruent. But it's the ICD that is used by insurance companies for the most part.
So the insurance companies say you have to have an ICD number to get reimbursed.
Yeah, right. And there might be some insurance companies that use the APA, but I don't know of them. And so when we do diagnostic classifications, we'll often use both numbers in terminology from both the ICD and from the APA. And like I say, they're fairly interchangeable. There's some differences, but there's not a lot.
Not a lot. Okay, so I come in and I see you, and you say, tell me about yourself, what brings you here today? And I say, I'm hearing voices.
Okay.
And so I go through a number of other things that are troubling me, and you end up saying, I'm going to give you a diagnosis of, maybe you don't say it to me directly, but you're a paranoid schizophrenic.
Yes.
So that would be one classification under DSM, and similar but not necessarily exactly identical classification with the World Health System.
Yeah, that's essentially it. And this is always changing and evolving over time. The initial classification system goes back to prior to the beginning of the 20th century, when it was useful to classify patients in mental hospitals with different kinds of disorders. And so the very first classifications, as we mentioned last week, had to do with diagnoses of people who have really serious psychiatric problems, so serious that they would be patients in an institution.
Yeah, and some of those patients, Jim, if my reading is correct, they might have had actual physical problems as well as functional problems.
That very, very correct. Yeah, the first group of people who were diagnosed, for the most part, had what we would now refer to as psychotic disorders. They were out of touch with reality, and or they may have had some physical problems, such as brain injury, brain damage.
Okay,
so there's remember the expression "mad as a hatter"?
Yeah.
Okay.
Yeah.
Well, hatters used a lot of mercury in their trade, which causes what? Brain damage.
Brain damage, yeah. So if you became a hatter in Victorian London, the chances were that after 10 or 15 years working in the trade, you would be mad as a hatter.
Mm-hmm. And you spoke of Victorian London. That's a time and an era where it really wasn't safe to drink the water, right?
Right. In fact, one of the first studies of cholera, the doctor who was studying it looked at patients, and it was the first really geographic study that anybody had ever done. He plotted them on a map of London, and he eventually found out that they were all drinking from the same public well.
Mm-hmm.
and that was giving everybody who did it cholera.
Okay. And so the alternative there is to drink the ale, right?
Right.
And apparently Victorian London residents drank a prodigious amount of ale.
Yes, they did because it was safer than drinking water.
Hmm. And this could lead, in some cases, to what we will later call Korsakoff's syndrome, which then goes along with severe emotional disturbance as well. So it's a physical cause of an emotional condition.
Okay.
Okay.
So the people at this time, if I remember right, Jim, they were the very early psychiatrists, rather than what we later came to be called psychologists.
Right. So the APA, the American Psychiatric Association, is a lot smaller organization than the American Psychological Association, but they were the group that were charged with treating or helping or facilitating treatment for hospitalized patients. And so it became, as we mentioned last time, it became handy to be able to talk to your colleagues about the patients that you might be treating in some sort of a shorthand manner. And so if I were to say to a colleague that Ralph is a paranoid schizophrenic, it's probably pretty safe that my colleague would know what I was talking about and would know some of the characteristics of Ralph.
Okay, now that would be true today.
Mm-hmm.
But originally, it might not have been true. And the reason for that, and I'm going to give our listeners two words that might be new to some of them. One of them is nosology, which is the formal study of setting up of taxonomy, which is the other word. And taxonomy is a classification of things. It could be anything. It could be a biological term. For example, if we think of the California condor, a big, graceful bird, you see them flying, they're amazing. They have about an 8-foot wingspan. But when you look at their taxonomic classification, they're what they call an obligate carnivore, an obligate scavenger. And that means that they eat nothing but dead flesh.
Okay.
So they look so beautiful, but when you see them on the ground eating a dead sheep, they don't look nearly as beautiful.
Okay. Well, nosology. See, I thought that was the study of noses. So thank you for and taxonomy. So it's a way of having a shorthand description. And so they began to, when I say they, the psychiatric profession began to write down some of the nosology or taxonomy, and they assembled it into the book that we talked about last week, the DSM, Diagnostic and Statistical Manual. And it's now been in its fifth edition, even though it started back in the 1920s or so with DSM1, Diagnostic and Statistical Manual 1.
Yeah, and that first edition was basically a little skinny paperback, cost $3, and had what, 128 classifications?
I think about that, yeah. So not a lot, but not as well. We'll get to the DSM-5 in a couple of weeks, and so 120 some classifications of people who mainly had severe psychotic behavior and or organic behavior, right?
Organic brain damage or function impairment of some kind.
Mm-hmm.
So, for example, today you might say, I think my friend is depressed. Now, they're still going to work. they're still functioning in society, but they don't seem happy anytime. But in the early days, the kind of people that psychiatrists sought with depression, they were people who were literally in a mental institution and couldn't get out of bed.
Yeah, right, in a vegetative state. So that the DSM-1 had maybe three major parts to it. They discussed the psychoses, they discussed the neuroses, which popularized by psychoanalysts in the early
Yeah.
1920s, or character disorders.
Okay.
So those are the three major classifications, and they were broken down into these 128
Different gradations.
Yeah, yeah.
So one of the things then that if I, for example, had a habit of punching people out when they said something I didn't like, they might say, well, this is not a psychotic situation, this is not a neurotic situation, this is a character disorder.
Right, an antisocial personality
Disorder.
perhaps. Yeah,
Yeah.
At least that's what we might go with that, today. So we've gotten some new statistical approaches to the to data in general, and one of them was a factor analytic approach. And so the factors on the DSM-1 were looked at, and they found that there was a lot of overlap with the factors. And so this means that maybe the reliability of the DSM-1 and the validity of the DSM-1 was somewhat suspect. So
Okay.
what do we do now? Well, we think about a DSM-2 where we try to remedy some of the perceived problems of the DSM-1. So we go
Okay.
from a booklet that's 113 pages to a larger tome, right?
Right. So the interesting thing is that the larger tome is actually smaller, but it's organized more into discrete categories.
Okay.
Now, when a logical thing you might ask, Jim, since you mentioned factor analysis, a logical thing we might ask is, why do they call it the Diagnostic and Statistical Manual? Well, that's exactly it. We are using statistics to help us form our definition.
Mm-hmm.
So we do factor analysis and we say, okay, there's 9 categories, and somebody else does a analysis of the same study and says, no, there's 5 categories. Well, we can fight that one out, but basically we have agreed that there are categories based on stats.
Correct. And so the DSM-2, which came along, is actually a little tiny bit bigger than the DSM-1. DSM-1 was 113 pages. DSM-2 was 119 pages. And it cost a little more. Cost 50 cents more than the original edition. So
Okay, so now we're up to 350.
Yeah. We'll see a real price jump as we go along historically with these documents.
Now, I have to tell what I think is an absolutely hilarious story here, Jim. Between the DSM-1 and the DSM-2, when they were looking at what they needed to change or add to the DSM-2 to make it more reliable, a guy named Overall conducted a study because he wanted to see something about the reliability of the DSM-1.
Okay.
What he did was he took a number of psychiatrists, psychologists, and he sent them into mental institutions.
Okay.
So they went in, and the only thing they didn't say when they went in was their real name.
Okay.
All their other histories were the same as their real histories. And they said, I think I needed to be admitted because I'm hearing voices. I either hear them say empty or thud. So these guys were admitted.
Mm-hmm.
And they were given whatever treatment the institution thought was apt to be effective.
Yeah, and they were given a diagnosis too.
They were given a diagnosis, yes, and all of them were diagnosed as schizophrenics. They stayed for an average of 19 days. The earliest release was 7 days, and the longest was 52.
So they were released as being cured, right, Ralph?
Right. Now,
Not so, is it?
what's interesting is that when they were in, all of the patients in the institution spotted them as fakes,
Mm-hmm.
but the doctors did not.
I remember that study. Yeah.
And I think that is truly funny that in this case the patients were more astute than the doctors over who was faking.
Mm-hmm. And speaking of diagnosis, they were not diagnosed. They were not released as cured. They were released as having psychotic symptoms in remission, which means that
we expect you to come back.
Yeah, that's right. Yeah. So even with the DSM-2, there was a lot of disagreement as to what the diagnoses might be. There was a lack of reliability, and without reliability, you don't have good validity. So this is going to set the stage for the third act, which is what we'll talk about next time, and that is the DSM-3.
Now, the interesting thing about DSM-3, and not to give everything away, but DSM-3 was a real sea change. Up until this point, DSM-1 and DSM-2 defined things in short, basically under 200 words, prose descriptions. In other words, 1 or 2 short paragraphs saying basically the patient in this classification is like this. And so you as a clinician would read that description and say, does this patient fit that? And if they did, you could give them that diagnosis. If they didn't, then you would have to go on to something else.
Mm-hmm. And like you say, Ralph, we're not going to give this one away, but we're beginning to look at, with DSM-3, the effect of the illness on what we refer to as global functioning. Because, hey, there could be people who are diagnosable who don't have any difficulty functioning at all, right?
Yeah, now, for example, the guy that you think is depressed, that I gave as an example earlier, if he's going to work, looking after his family, basically completely functional, except you think he's anhedonic, another fancy word for never happy, does he need treatment? Well, maybe not. I mean, maybe he's perfectly happy.
Okay, so until the next time when we get into the murkier waters of DSM-3, this is Jim
And Ralph,
saying, keep your stick
on the ice
because we're all in this
together.